A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Assalamu alaikum everyone and welcome to my channel. This is Asif Qureshi and you are watching Dr. Asif Lectures. In the previous video, we talked about various presentations of adrenal disorders. I hope you have already watched the video and liked the video and shared the video. I am also giving the link of the video in the description of this video, okay? Once you have gone through the adrenal pathologies and adrenal management options and adrenal diagnostic algorithm, now is the time to discuss some important MCQs which can come in your examinations, different board exams, okay? So let us begin with the first question. The first question says, which one of the following is not the function of aldosterone? Now, usually in the examination, such questions saying not are either they are not usually there, or if they are there, they are difficult for the student because you need to, rememorize in your head that what are actually the functions. Once you are very sure that what are the functions, you can easily pick which one is not, okay? So let's see the option. Options are salt retention, water retention, increase in blood pressure, hypokalemia, and metabolic acidosis. Now, if you remember my previous lecture, we emphasized again and again and again that aldosterone performs this: salt retention, water retention, potassium excretion, which will produce hypokalemia in the body, and hydrogen excretion, which will produce metabolic alkalosis in the body, okay? So now you pick up the right answer. I hope you now already know that what is the right answer. So let's go one by one. Salt retention, is it not the job of aldosterone? It is. So A is not the right answer, okay? Water retention, it is one of the jobs of aldosterone. Increase in blood pressure, because of salt and water retention, the blood pressure goes up. It's a function of aldosterone, okay? Hypokalemia, this is what it causes. But hey, look here, metabolic acidosis. This is not something which it causes. Actually, aldosterone causes metabolic alkalosis. Increase in aldosterone causes metabolic alkalosis. So it's a metabolic alkalotic kind of hormone, okay? So that is the right answer. This is not the function. Metabolic acidosis is not the function of aldosterone, okay? I hope this question is very much clear to all of you. Let us now move on to the next question. Now, which one of the following is not true for, again, it's a not true for kind of question, 11-beta hydroxylase deficiency. Which one of the following is not true for 11-beta? You remember when we were discussing the cholesterol pathway where cholesterol was being converted into pregnenolone and so many other products. It was generating 3 hormones from the adrenal, and those were aldosterone, cortisol, and androgens, okay? And in those long complicated pathways, I discussed with you 3 important enzyme deficiencies: 17-hydroxylase deficiency, 11-hydroxylase deficiency, and 21-hydroxylase deficiency. So this question is focused on 11-beta hydroxylase deficiency, and it's asking about which one of the following is not happening in this deficiency, okay? Low cortisol, low aldosterone. This is what happens if you remember. If this hormone pathway was blocked at the level of 11-beta hydroxylase, there was low production of cortisol, there was low production of aldosterone, there was high production of androgen. So option A, B, and D are the wrong options. Decrease in blood pressure, C, and the last one is E, increase in 11-deoxycorticosterone. Actually, if you remember, increase in 11-deoxycorticosterone happened, and because of that, the blood pressure was also high. So in this particular question, the right answer is that the blood pressure is not going to decrease, it's actually going to increase. And we discussed in detail that although aldosterone level will be low, but the blood pressure will be high. Not because of the aldosterone, but because the precursor of aldosterone, 11-deoxycorticosterone, was high, okay? So you can refer to my lecture for which I have given the link in this video already. Which one of the following drug inhibits cortisol receptors throughout the body? Pretty simple, straightforward. Such questions in the examination are called single stage question, level 1 question, where they are simply testing your understanding that do you remember what was taught to you. And we discussed in the lecture that the drug called mifepristone blocks cholesterol receptors throughout the body, okay? So this is one of the treatment options during hypercortisolism. Pretty straightforward question it was, wasn't it? Next question is hyperaldosteronism due to adrenal adenoma. Now that should ring bells in your head, that hyperaldosteronism, what are we talking about? Increased aldosterone levels. And increased aldosterone levels can be because of the primary problems, that is something wrong within the adrenal, can be because of the secondary problem, which is something wrong at the kidney level. Okay, remember that? Where low blood pressure, renal artery stenosis, cardiac failure, liver failure, all those sort of things used to stimulate renin. So more renin and more aldosterone, more renin and more, so that was secondary hyperaldosteronism. So this question is talking about if hyperaldosteronism is because of adrenal adenoma, so that's a primary cause, and then it says it is also known as. That's again a simple level 1 question. Guys, primary hyperaldosteronism because of adrenal adenoma is known as Conn syndrome. Okay, it's a pretty straightforward answer. It cannot be B, Cushing syndrome, because Cushing syndrome is to deal with hypercortisolism, not hyperaldosteronism. Okay, Addison's disease is not a hyper condition. Addison disease is a adrenal insufficiency. It's a hypo condition. Okay, so C cannot be the right answer. D, Cushing disease. Cushing disease is hypercortisolism because of a pituitary adenoma. Okay, so that is again to deal with cortisol levels, not aldosterone levels. Okay, incidentaloma doesn't make sense here. So A is the right answer. Bang on, spot on. A, and if you have picked up A, this means you have watched the previous lecture very, very carefully, and I'm glad about it. Okay. Okay, another pretty straightforward level 1 question. Look here, look, which one of the following is a characteristic finding in primary hyperaldosteronism? Now let's talk about it. Whenever I solve questions, you know, I first of all study the vignette and then figure out in my head, where are we? Okay, now when we talk about primary hyperaldosteronism, that should be very clear in my head that there is something wrong within the adrenal gland. And if there is something wrong within the adrenal gland, and due to this, more and more aldosterone is produced, so levels of aldosterone will be very high. And what will be the levels of renin? Because the level of aldosterone is very high, it will suppress the level of renin. Okay, so in this condition, you will typically see high aldosterone and low renin. Now look the options. Look out for the options. The first one is high renin and high aldo. It will not be high renin, guys. In primary hyperaldosteronism, it's not going to be high renin. It's high aldo and low renin. Look option number B. Low renin, low aldo. No, low aldo cannot be an option because we are talking about a hyperaldosteronism. Hyperaldosteronism. And low aldosterone, B is not the right answer. Look at C, low renin and high aldo. This is what we talked about, didn't we? That in primary hyperaldosteronism, there is increased aldosterone levels which inhibit renin. So high aldo, low renin. There you go. This is the right answer, okay? This is the right answer. The next option, option D, was high renin and low aldo. Doesn't make sense. Why high renin and low aldo? Low aldo? No, this is hyperaldosteronism, okay? And the last option is normal renin, normal aldo. If it was normal renin and normal aldo, it would not have been called hyperaldosteronism, okay? So clear, short, easy question. Only if you remember the details from the last video, okay? I'm again saying to master the adrenal glands, please visit the video for which I've given the link in this description. Okay, the next question, pretty similar one. Now it is asking about which one of the following is the characteristic feature, not for primary, but secondary hyper. So clearly it should be in your head, it's a hyperaldosteronism condition. So aldosterone levels will be high, but now this is secondary, which means the renin levels will also be high. And when renin levels are high and aldosterone levels are high, look for the option. Where is it? Where is it? High renin and high aldo. Option A is the right answer. All the other we can discuss. B cannot be the right answer. Low renin doesn't happen in secondary hyperaldosteronism. So, and low aldo anyways is not the right option because we are talking about hyperaldosteronism. So B is out of question. C is the typical scenario for primary hyperaldosteronism. High aldo, low renin, okay? And D, high renin and low aldo. Again, low aldo doesn't make sense, okay? Because this is hyperaldosteronism question. and E is absolutely out of question. So see how easy is it to approach the question? Read the clinical scenario, try in your head to figure out what exactly happening, and then read the options, okay? And then pick the best option. Let's move on to the next question. Now, which one of the following is the mode of inheritance? Oh, genetics? Did we not talk about genetics? Let's see. Which one of the following is the mode of inheritance for 17-hydroxylase deficiency, 11-hydroxylase deficiency, and 21-hydroxylase deficiency? All of them. Steroid hormone synthesis pathway. All of them, these deficiencies are, I told you in the lecture, at least for one of them, applies to all of them, they are autosomal recessive. Okay, so again, this is a level 1 question. They are autosomal recessive. All the other options are out of question. Okay, next question, pretty simple as well. Which one of the following is not true about pheochromocytoma? Remember, I told you a rule of 10% norms in pheochromocytoma. They are 10% of the times malignant. They are 10% of the times in children. They are 10% of the times bilateral. And they are 10% of the times extra-adrenal. If you remember this, you should immediately point out that option A is out of question. They are not 10% benign. They are 90% of the times benign. Most of the times they are benign. Only 10% of the times they are malignant. Okay? So option A is not true. Option A is not true in this scenario. Woo, woo, woo. I like this one. Now here we have got a clinical scenario. Here we have got a clinical vignette. Okay, let's go through it. A patient sustained road traffic injury to his head and severe abdominal trauma and is now sent to the ward from the emergency. So try to imagine and picture the scenario. There was a patient who had a road traffic trauma where he has injuries to his head and abdomen, was brought to the emergency, and now the patient is in your ward. So you are taking care of the patient now, okay? Now he suddenly becomes hypotensive, he loses his blood pressure, and there is no evidence of bleeding. So obviously, this is a road traffic trauma type of patient. If there is hypotension, you will obviously look for the source of bleeding for hypotension, but you didn't find any. There is no source of bleeding identified, okay? And this is important clue in the question, and we'll talk about why. He's also febrile, he's also having fever, okay? And labs show eosinophilia, there is high eosinophil count, low sodium, high potassium, low glucose. And what would you do next is the question. Now guys, that's important. In a good examination question, each and every word, each and every line has a meaning, and each and every line is pushing you towards the right answer. Okay, so let's try to figure it out. What are the clues here and what is the right answer? So what do you think the patient is developing? You know, the patient is developing hypotension, the patient is hyponatremic, so he's unable to reabsorb sodium, is hyperkalemic, is unable to excrete potassium, is also unable to maintain glucose levels, is hypoglycemic, has fever, has low blood pressure. Does it not sound to you like Addisonian crisis? Addison crisis, do you remember? If the patient has chronic Addison disease, and if there is a precipitant, I told you, if there is an event, and that event can be a trauma, surgery, infection, that will precipitate Addisonian crisis. So this patient is going into Addisonian crisis, which is an emergency. And you have to, I told you, you don't have to wait for the labs. In the previous lecture, you remember, I told you, you don't have to wait for the labs to begin the management of this patient. Now look at the options. The question says, what would you do next? First one is CT of head and CT and MRI of adrenal, out of question. I told you already that do not begin with the scans in a patient with an endocrine problem. Scans can be done later on, okay? You don't have to worry about them in an emergency situation right now. So A and B, out of question. Short synactin. Short synactin was done, when was it done? Do you remember? That was to address the cortisol issues. So this is where we are thinking about Addisonian problem. Addisonian problem, Addisonian crisis. You are not going to order any type of test? Well, it could have been better if there was a chance to do short synectin, which requires 30 minutes, but this patient is critical. You cannot wait for 30 minutes, okay? So that is out of question. ACTH levels, forget about it. You're going to send it to the lab and the results are going to come back and it's going to take time. You don't have time for this. And the last one is draw blood for cortisol and start management. Inject hydrocortisone. That's the right answer. And this is what I told you already. In a patient where you are suspecting Addisonian disease, you take out the blood for lab testing, send them, but do not wait for the results to come back. Start the management. And immediate management would be inject hydrocortisone. Inject hydrocortisone, okay? And the patient should improve on this dose. You have to save life. And these questions are designed in a way to train you to save lives, okay? We cannot afford to wait for CT scans or ACTH results or short synectic tests, waiting for half an hour for cortisol levels to rise. If they rise, I would know this is primary or secondary. We don't have to worry about it at the moment. Short synectic is to locate if it's primary or secondary problem for the cortisol. We don't have to wait for this test at this moment. Patient is in crisis. Patient is in crisis, okay? Let's move on. Next question is, which one of the following is least seen in Addison disease? Which one of the following is least seen in Addison disease? Now figure out what is Addison disease. Addison disease is something where adrenocorticotropic hormones are less. It's a hypo condition. So aldosterone will be less, cortisol will be less, androgens will be less, okay? So let's see what are they talking about. The option, metabolic alkalosis. Think about it. Can metabolic alkalosis be the right answer? If aldosterone is low, hydrogen will not be secreted, and if hydrogen will not be secreted, it will be obviously in the body, which will mean alkalosis will happen. So in Addisonian problems, in Addison problem, metabolic acidosis will happen, not alkalosis. So I think this is the right answer. Straight on the first one, I bang on that, okay, it doesn't fit my learning curve. I learned that if there is no aldosterone, hydrogen will not go out. And if hydrogen will not go out, it will stay in the body. And if it stays in the body, it will cause metabolic acidosis. And this option says alkalosis. Wrong answer. Wrong answer. Okay? So I'm pretty confident that this is the right answer here. So this is what they're asking. Least expected in Addison disease. So it's not actually it's the right answer, but the description is obviously wrong for Addison's disease. Okay? So this is the pickup. Right questions answer, and I hope you also went with metabolic alkalosis. Now also go through the other option. Hyponatremia will happen? No, it will not happen. Hypernatremia will happen. Why? Because if there is no aldosterone, sodium will not be properly reabsorbed into the body, and if it's not reabsorbed, oh yeah, it will actually happen. So yeah, just I beg your pardon. It flipped around in my head actually, okay? So we are talking about Addison disease. Addison disease, there is no aldosterone. If there is no aldosterone, sodium absorption is a problem, okay? So it will lead to hyponatremia. Hypoglycemia, yes, because there is low cortisol as well. And if there is no cortisol, you remember I told you cortisol is a diabetogenic hormone. So if there is no cortisol, glucose levels will go down, okay? Hyperkalemia, obviously, if there is low aldosterone. So what are we talking about? Addison disease. Addison disease means low aldosterone, low cortisol. So if there is low aldosterone, potassium will not be excreted. And if it's not excreted, it's within the body, okay? So hyperkalemia will happen. And a positive short synectic test, yes, this will happen. This will happen. So if in this patient you give an intramuscular injection of ACTH at 0 minutes and 30 minutes, if you check it later on, cortisol levels will rise, so which is called positive short synectic test. This will happen, okay? So all options from B through to E, they will happen, but the least that will happen is metabolic alkalosis, okay? So you know metabolic alkalosis, option A is the right answer because this will not happen in Addison disease. Let's go to the next question. Very interesting. Another long case scenario, another long vignette, clinical vignette, which we need to discuss, and let's go through this one now, okay? It's a 42-year-old male presents to your clinic with repeating episodes of headache. Important point, okay? Repeating episodes of headache. You should already be thinking about something. Next it says he also complains of sweating and palpitations. Oh my God. He measured his blood pressure, which was very high on several occasions. So high blood pressure, palpitations, sweating, headache. Well, I can tell this is going towards pheochromocytoma. This is heading towards pheochromocytoma, okay? What is the next best step in the diagnosis of the suspected disease? So this question is a level 2 question where they are giving you sort of presentation, and then they are expecting you to, have a diagnosis in your head, and of that diagnosis, what would you do next, okay? So let's see the options. CT scan of abdomen, MRI of abdomen, 24 hours urinary metanephrines, 24 hours urinary VMEA, and 24-hour serum catecholamines. Now, option A and option B are out because I've clearly told you that the next best step in the management in an endocrine problem is usually not a scan, unless you get the biochemical profile in hand. So get the biochemical profile first and then do the scan. Here, we don't know about the biochemical profile, so we will rule out the scans. We don't do CT scan of abdomen or MRI scan of abdomen. A and B are out of question, okay? Now, look here. Option C, D, and E, all can be done. Because here you are expecting pheochromocytoma because of the symptoms. Pheochromocytoma, you can do plasma catechol levels, you can do urinary all metabolites level, you can do urinary epinephrine, norepinephrine levels. So they are all okay, but you have to go for the most accurate, most sensitive one, okay? Which is, I told you in the previous lecture, 24-hour urinary metanephrines, okay? You cannot rely on catecholamine levels because, as you know, I told you in the last lecture that catecholamine's half-life is very, very short. So therefore, the sensitivity is not very great, okay? So you have to, this one is a more acceptable, more sensitive and more accurate test. So the best option here would be 24-hour urinary metanephrine levels if you are suspecting pheochromocytoma. If the levels are very high, then you will go for scans. Then you want to then see that where is the tumor, how big is the tumor, what is the depth of the tumor, what is the exact location of the tumor. But the scans come after biochemical profile, okay? I hope this question is very, very clear to you. So see how beautifully they gave you the presenting complaints, you identified this is pheochromocytoma, and then this is testing your knowledge and what should be done next, okay? And this is not anything that we have not discussed in the previous video. Now, a very straightforward question. Middle suprarenal artery is a branch of, it's pretty straightforward, it comes from aorta, okay? Now let us discuss the next question. A 42-year-old female recently diagnosed with type 2 diabetes mellitus, okay? She presents to your clinic with hirsutism, stria on the abdomen, and also with the complaints of moon face. She tells you that her facial appearance has changed and people tell her that she is becoming round as moon, okay? You should be able to, up till now, identify that this is pointing towards Cushing syndrome, okay? Let's read the next statement. They say that Cushing syndrome is at the top of your DD list. Now, that's interesting, you know. They already know, the question writer already know that you have attended Dr. Asif Lectures and that you know if there's a patient coming to you with diabetes problem, moon faces, buffalo hump, stria on the abdomen, you are already thinking about diagnosing this patient as Cushing syndrome. But they want to make life difficult for you. They don't want to ask you what is the diagnosis, they want to ask you something else, okay? Let's see. Which one of the following lab should be expected in this patient? So they are actually telling you some presenting complaints and they are themselves telling you that the diagnosis in your head is Cushing syndrome, and now they want you to know what will be the laboratory findings, okay? Now, laboratory findings, if you read the options, say hypercalcemia, hyperkalemic metabolic alkalosis, hyperkalemic metabolic acidosis, hypokalemic metabolic acidosis, and hypokalemic metabolic alkalosis. Now, the scenario looks very easy, Cushing syndrome, but the options, they look complicated to many of the students, okay? But I'll make life easy for you. So in order to crack this question, you need to understand that we are talking about Cushing syndrome. And Cushing syndrome means high cortisol. And when cortisol is present in very high levels, it starts acting on aldosterone receptors. So high cortisol will start having aldosterone functions, okay? Aldosterone effects will be now more visible because of the cortisol. So if you have this understanding, now you can crack this question. Because now all you need to do is think about what does aldosterone do. Aldosterone does, it throws potassium out of the body. So it will cause hypokalemia, okay? So the answer has to be from option D or option E, from the hypokalemic options, okay? Now think about it, it causes metabolic alkalosis or acidosis. When I say it, I mean aldosterone, because cortisol is now equal to aldosterone. It is acting on the aldosterone receptors. So it basically causes alkalosis because it throws hydrogen out as well. So the right answer would be hypokalemic because it throws potassium and it also throws hydrogen. So that's the right answer, hypokalemic metabolic alkalosis, okay? So patient with Cushing's description will have this laboratory finding, okay? So look difficult, but it's pretty easy if you have the basic understanding that increased cortisol can act on aldosterone receptors, okay? Let's move on to the next one. Which one of the following drugs block the action of aldosterone? Pretty straightforward, simple question. Pharmacology students love this question. Very straightforward, okay? Options are aminoglycosides, spironolactone. How guys, you know this. This is spironolactone. I told you in the lecture that spironolactone blocks the action of aldosterone on the collecting ducts of the kidney. Yeah, you remember that? On the principal cells and the intercalated cells, where aldosterone's main function happened, throwing potassium, throwing hydrogen, reabsorbing sodium, reabsorbing water. Remember that? So that action is blocked by spironolactone, okay? Let's have a look at the next one. Again, a long question. Clinical scenarios I like because there is a lot more to discuss in the clinical scenarios, okay? Now, there is a 51-year-old male admitted to the emergency unit with severe fatigue. I am tired and severe fatigue, and the blood pressure is kind of low, 100/50, systolic and diastolic, and there is also low temperature, hypothermia. So start thinking about what could that be. In my head, I can have the diagnosis, differential diagnosis. The patient has fatigue, hypotension, and hypothermia. Yeah, you think about it, what it is. Park in your head, and we will talk about it. The patient gives you the history of Graves' disease. Oh my God, now this is complicated. From the first couple of statements, I thought it's going to be Addison disease because the patient has fatigue and the patient has hypotension and the patient has hypothermia. I was thinking of Addison disease, and I'm sure you were also thinking of the same. But now they are telling you the patient has a history of Graves' disease, something to do with thyroid problem. My God, they're confusing me. Let's go ahead. Now, the laboratory findings are sodium is 135, potassium 135 is pretty normal, and 5.4 is the potassium, pretty much on the higher side, okay? Usually in the examinations, they give you normal range in the brackets, but I'm telling you here, the sodium is normal, potassium is on the higher side, TSH is okay, free T4 is okay, which means there is no Graves' problem at the moment, okay? And you order cortisol. You are still convinced. You are still convinced that this is an Addison problem. Okay, so you order cortisol levels as the first thing to do in Addison suspect. And when the cortisol results have yet not come, so you are waiting for the cortisol results, okay? And the patient collapses. Bad news. Bad news. You were so happy that you are diagnosing the patient in the right direction. You think the patient has a decent problem, insufficiency of adrenal gland, low cortisol, low aldo, low androgens, and suddenly your patient collapses, okay? And the question is, what is the next best step in the management? The options are arrange a CT scan, I told you, is the wrong answer. The patient is collapsing. Arrange an MRI, wrong answer, okay? Check and address the glucose level. Checking glucose levels is really important in this scenario. You know why? Because we are thinking of Addison problem, yeah? And in Addison, you know, there is low cortisol, low aldo. So low blood pressure, hypothermia, and low glucose. And the glucose can go as low, as much that the patient can collapse. And perhaps this is the problem here. Immediately prick the patient, measure the glucose levels, and IV dextrose saline, 10% dextrose, okay? So perhaps this is the right answer, but let's see what is the next option. So perform on overnight DEXA. Overnight DEXA in a patient who has collapsed? You're kidding me? No, you don't do that, okay? And short synaptic, no, you don't have time to wait even for 30 minutes, okay? And you are not interested in what results come out from short synaptic. You know the patient is collapsing, you are suspecting cortisol levels will be down, and there is hypoglycemia. So the best management plan out of these options would be check and address the glucose level. So here is the beauty of practicing medicine. If you understand everything in totality, I told you yesterday, In the previous video, I told you that my concept of mastering the medical science is that you have to understand anatomy, physiology, biochemistry, pathology, patient presenting complaints, diagnosis, management, all under one roof in one go. You have to understand every organ of your body in totality. You just can't do that. I know only medicine bit, but I don't know the pathophysiology. If you don't know the pathophysiology, you are not going to understand medicine. This is as simple as that, okay? So see, you have to pick up the right answer, and you can only do so if you have, mastered it. Not only read it, but mastered it, okay? And that's what we are here for. Dr. Asif Lectures on this medical series, they are here to help medical students to master the medical sciences, okay? Let's have a look at the next question. A 43-year-old female comes to you with the complaints of hirsutism, headache, loss of libido, and high blood pressure. Again, you are thinking of Cushing syndrome. Pretty straightforward, okay? Now you are suspecting, oh my God, whenever I think of a diagnosis, they tell me the diagnosis. Then I wonder, what are they actually going to ask me? Okay, let's see. Now they are telling me this is I was thinking Cushing syndrome, and now they are already telling me this is hypercortisolism because of Cushing. Oh my God. What would be your next best step in diagnosing the condition? Okay, so here is a patient who has complaints which are very much, pointing towards Cushing's problem, and you are thinking this is a Cushing disease, hypercortisolism. Now they're asking you what is the next best step in the diagnosis, because you have to fix the diagnosis. And remember, I told you the first thing in establishing the diagnosis of hypercortisolism is, number one, to establish that the cortisol levels are high. Once you have established this, then you need to do is establish the source of high cortisol production, okay? So that was the diagnostic algorithm. Initially, fix if it is really high cortisol levels, and if the cortisol levels are high, from where are they coming, okay? Now let's look at the option. The first option is high-dose dexamethasone suppression test. You remember when was it done? We will discuss it now. CT scan, pelvis, CT scan, chest, 24-hour urine cortisol, and short synectin test. Now, all of them, one of them should, you should remove one option straight away, because that doesn't fit in the scenario here. And that is option number E. Short synectin is done when you are suspecting low cortisol production, okay? And therefore, that's a stimulation test. It's a stimulation test. You give ACTH and try to stimulate cortisol. So here, we don't have a problem with low cortisol. We have a problem with high cortisol. So option E is out. Because you know from my previous lecture that short synectin was done when you were suspecting low cholesterol. Here it is high cholesterol. Not cholesterol, sorry, cortisol. So short synectin is for low cortisol. But in this clinical scenario, we are dealing with high cortisol levels. Okay, so option E is out. Now, the remaining question, yes, we do high-dose dexametha. Yes, we do CT scan pelvis. Yes, we do CT scan chest and 24-hour urine cortisol. They're all done, A to D, all done in the diagnostic algorithm of hypercortisolism. But the question is, what is the next best step? What is the next best step? The next best step is not a CT scan. The next best step is not a CT scan, because we need to get lab profile first, biochemical profile, okay? So option B and C are out. Now we are left with option number A and option number C. So option A, high dose, if you remember the diagnostic algorithm, high dose dexamethasone suppression was actually done later in the diagnostic algorithm to figure out the source, of high cortisol. Our problem here is to, number one, identify if cortisol is really high. So you first need to do a test which tells you that yes, cortisol levels are high. Then you will do a test which will tell you where is it high, okay? So the first test would be, in this scenario, 24-hour urinary cortisol levels, okay? So that's the right answer here. Simple, logic, sense. It should make sense to you. If it doesn't make sense to you, go back to my video, watch the video again, an hour and 20 minutes video, watch it again and again and again, unless you understand this. Once you understand this, you have mastered it. And you will remember it for the rest of your life, because I'm not teaching you to rectify things. I'm trying to explain things to you so that you understand, okay? Let's move on to the next question. A 42-year-old female comes to you with complaints of weight gain and hirsutism, again looking like Cushing syndrome, okay? She has high blood pressure, looking like Cushing syndrome. Sodium looks normal, potassium looks a little low, Why? Because high cortisol will act like aldosterone, and aldosterone will throw out potassium from the body. You understand it. Bicarbs, showing you a picture of alkalotic environment, and this is what cortisol high levels do. What do? They act like aldosterone. They throw out potassium, they throw out hydrogen, okay? So these labs are telling you hypokalemic metabolic alkalosis picture, yeah? Now, the question is, which one of the following is the next best step in the diagnosis of this? Again, the next best step. Whenever there is hypercortisolism suspected, step number 1, see if the levels of cortisol are high. Step number 2, see from where the levels are being secreted very high. So number 1, establish the levels of cortisol. Number 2, establish the source of high cortisol, okay? So again, CT scans are out of question. Short synectin is out of, and you know why it is out of question. Short synectin is done when you are suspecting low cholesterol, I'm again saying cholesterol, low cortisol levels, okay? Low cortisol levels. Now, high dose A and C are again, A and D are the left ones. High dose dexamethasone and overnight dexamethasone. Again, I told you, high dose dexamethasone is used to establish the location of high cortisol levels, okay? And the option here would be D. Now, if you remember, in the previous lecture, I told you the first step is to do either salivary cortisol levels in the night or do the overnight dexamethasone suppression test, 1 milligram, yeah? Or do the 24-hour urinary cortisol levels. These are the 3 tests you have to do, or any one of them. The most accurate, some people say it's 24-hour urinary cortisol, some people like overnight dexa more, 24, there is consensus that 24-hour urinary cortisol level is the most accurate one. So remember, of these 3, you do any one or a combination to establish that cortisol levels are high. Once cortisol levels are high, then you were doing, if you remember, ACTH levels. So if ACTH levels were low, it was a problem either within the adrenal gland or you were taking exogenous steroid. If the ACTH levels were high, then you were doing high dose dexamethasone suppression test to see if the problem is within the hypothalamic pituitary axis, or if the problem is somewhere else. Is it in the lung cancer, for example, okay? So we discussed that algorithm earlier on in the previous lecture. But remember, first do a test which tells you that cortisol level is high. Then do a test which tells you what is the location of the high cortisol, okay? So in this scenario, overnight DEXA suppression, which is also called the low dose dexamethasone suppression test. Another big question, a 31-year-old female is being suspected for Addison disease, they're telling you, okay, due to her fatigue, hypotension, and weakness. So they tell you the diagnosis, no problem for you up till there. A morning cortisol comes out to be 140 nanomoles per liter. They're also giving you the laboratory finding. What would you do next? Okay, so you are suspecting Addison. Addison means low cortisol, low aldosterone, low androgens. Low cortisol, and they did the cortisol level test, and it is coming out to be 140. Now, anything between 100 to up to 400 or even 500 is ambiguous area. Above 500, you are sure that this is not cortisol deficiency. If the levels are more than 500, you are sure 100% confirm that this is, you rule out hypocortisolism. If you remember the diagnostic algorithm we discussed for measuring cortisol levels, if cortisol levels are more than 500, you exclude hypocortisolism. Exclude it. Okay? You exclude Addison's if they are more than 500. But if it's between 100 to 400 to 500, that's a gray area. And this is something where you should do a further confirmatory test, which is short synectin. What do you do in short synectin? You give intramuscular ACTH and see if the cortisol levels are going up. If they're going up, that's a primary problem. If they're not going up, a secondary problem. So you need to understand that, okay? That what is the next best step? Her Addison's is resolved? No, it's not resolved. The levels are low. B, she has Cushing syndrome instead? No. In Cushing syndrome, cortisol levels are high, dude. They're not low, okay? So this is not the right answer. She should be referred to short synectin? Yes, yes, yes. D, same test should be repeated to be sure? No, no, no. You don't have to do that, okay? And E confirms the diagnosis of Addison. It doesn't confirm the diagnosis. You have to do another level test, which is short synectin. Okay? Let's move on to the next one. 32-year-old female presents to you with history of weight gain, high blood pressure, hirsutism, again Cushing syndrome, okay? ACTH is high, ACTH is high, ACTH is high. Now this is important. Only this one single word, ACTH is high, tells me that the problem is not within adrenal. And the patient is not taking exogenous steroid. Because if the patient was taking exogenous steroid or the problem was within the adrenal, ACTH level would have gone down because of the negative feedback loop. You remember that? You remember that? So if adrenal is producing a lot of cortisol, ACTH down. If the patient is taking exogenous steroid, ACTH down. So in this patient, ACTH is high. So since ACTH is high, it tells me that the problem is not in the adrenals and the problem is not exogenous steroids. Okay, let's go forward. Now, no cortisol suppression on overnight DEXA, and this will happen because if you try to suppress it, it will not get suppressed because it's high ACTH. The high ACTH will keep on pushing cortisol. So dexamethasone suppression, low dose will not work, okay? And then there was suppression, cortisol suppression on high DEXA. On high DEXA, there was a suppression of cortisol level. Now, this is important. This is important. This takes me to pituitary. This takes me to pituitary because you remember the diagnostic algorithm? The diagnostic algorithm of Cushing syndrome, the first thing you need to do is you establish if cortisol is high. And you do so by overnight dexamethasone suppression test, salivary, nighttime salivary cortisol levels, or you can do 24-hour urinary cortisol levels. So since the levels are high, then you go for ACTH level. In this case, ACTH levels are high. So if the levels are high, the next thing I would do is high dose dexamethasone suppression test. If it is suppressed, it means the problem is in the pituitary. If it is not suppressed, the problem is somewhere else, ectopic ACTH, lung cancer, stuff like this, okay? But here it tells you that on high dose dexamethasone suppression, it is suppressed. So I'm thinking of pituitary problem, okay? And similarly, the physician dealing with this patient also thought so, and he ordered scans. The MRI pituitary was negative. I made a diagnosis that this is something wrong within the pituitary, and now they are telling me that the MRI is negative. Bang. What should be the top of the differential diagnosis list? Now I'm confused, yeah? Let's see the options. Option A, exogenous. I told you it's not exogenous steroids. Why? Because ACTH levels are high here, okay? If the patient was on exogenous steroids, the ACTH levels would have been low, right? Cushing disease. Cushing disease is something which I was actually thinking. Problem in the pituitary. This is what I was thinking, but now pituitary MRI is negative, so I'm a little confused. Lung cancer, it is not lung cancer because if it was lung cancer, then high dose dexamethasone would not be positive. We look in this scenario that high dose dexamethasone is suppressing the cortisol levels, okay? ACTH levels. So therefore, this is not lung cancer. This is obviously not Cushing syndrome because that deals with hyperaldosterone condition. And it is not adrenal adenoma. I told you this is not adrenal adenoma. Why? Because ACTH levels are high. In adrenal adenoma, ACTH levels would have been low. Okay. So now I am only confused if B is the right answer. But I am pretty confident that the rest of them are not the right answer. So I will pick B. Now, there's one more thing which I need to discuss at this point. My only confusion, I'm 90% confident because the rest of the 4 options are wrong. I'm sure they are wrong. That's why I've picked up Cushing's. But I'm only confused because of the MRI pituitary is negative. Listen, guys, many pituitary tumors are so small that they cannot be picked up in MRI. So it is a routinely seen observation in clinics that you have a diagnosis, all the laboratory findings are pinpointing towards a pituitary problem and the MRI is negative. Why? Because maybe the adenoma of pituitary is so small that it is not being picked up in MRI. So this is something commonly observed, okay? And that's absolutely fine. So you have to trust your biochemical profile. You have to trust your biochemical profile in endocrinology, okay? Let's move on to the next question. Venus, bro, after so many difficult questions, that one is very easy, okay? And you tell me the answer straight away, inferior vena cava. I'm not gonna even read this one. That's straight level 1 knowledge, okay? And with this, congratulations. We have completed the course called Master the Adrenals. We discussed in a long lecture different anatomical things which are important for your board's exam pertaining to adrenal. We discussed physiology, we discussed biochemistry, we discussed clinical correlates, adrenal disorders, patient presentations, their diagnostic algorithms, their management plans, and then we discussed very, very important clinical cases today. that what would be the next best step in the management? What would you do next? How would you diagnose? How would you manage? And with this, I congratulate you for completing this Master the Adrenals course. I will soon be back with the next axis in the endocrine system. And stay tuned. Hope to see you in upcoming future videos. I once again request you to please subscribe our channel, share the videos, like the videos, and give your feedback in the comment section. Thank you very much.